wonderful session. And next, we are move on to the very important lectures, keynote lectures by the eminent world-class speakers. Two speakers we have. For this, we have two eminent chairpersons, Dr. Jyoti Dev and K.S. Dev, and Dr. Lily Rodriguez. Over to chairpersons. Dr. Lily.
Dr. Lily was there. She has.
I couldn't able to see them and Dr. Lily. Anyhow, it's a great pleasure and pride and honor to introduce our first speaker, Professor Philip Home. He's the past president of IDF Europe. He's the first vice president International Diabetes Federation, and he's the emeritus professor Diabetes Medicine at Newcastle University. He is going to enlighten us on the future insulins. Welcome, sir.
Okay, but I have a message saying you cannot screen share while other participant is sharing. So I can't put my lecture up.
RXT?
Yes, and now
yes.
You can sharing.
Please.
Let's try it again. Okay.
Yes, sir.
That looks okay. Thank you. Yes, and thank you for inviting me again to the organizers to speak to Diabetes India. Been doing so now for a long time, it seems, and it's always a pleasure to speak to you. This year, I have 30 minutes to talk about the future of insulin therapy, and it's the future of insulin therapy in its second century. How am I going to address this? I addressed a similar topic last year. On this occasion, I'm going to talk about overcoming the technical barriers to insulin therapy, using the ideas that are current and being published in the last few years, and indeed this year as well. So what are the barriers and how are they overcoming them? I do have, of course, dualities of interest in regard of insulin products, but they don't apply to any of the products I'm going to talk to, largely because these are unlicensed things and things which are not on the market as yet. I published last year a couple of articles, more than a couple, 3 articles there on insulin reviews. The first one is the backward-looking review, the last 100 years, as it were. And last year I talked a bit more to insulin therapy development beyond 100 years. So this year it's based on the metabolism article, Future Directions in Insulin Therapy. I have, of course, updated the technical searches to this current month. If we think about the physiological need for insulin, then this, of course, should be what's determining the nature of the technical insulin we give to patients who are insulin deficient. And the most important, perhaps, is the minute-to-minute, perhaps minute-to-5-minute regulation according to changing need. So obviously, without thinking about it, we vary our insulin secretion according to what we're eating and according to our physical exercise. And we vary it enormously, as we'll see, by a factor of 10 or more. Secondly, there is a fast reflex, partly neurological reflex, and incretin response to calorie consumption. You only need to look at food and you begin to secrete insulin in greater quantities. And that, of course, importantly, is not glucose regulated. Then we have the glucose and amino acid regulation after eating and in the basal state. And these 3 things I've talked about all occur very quickly and are regulated, as I say, on perhaps a 3-minute basis. Then there's the slower regulation, the regulation that occurs within day, hour-to-hour regulation according to changing need. And this occurs post-exercise when we become more insulin sensitive, post-hypoglycemia, similarly with concomitant illness and indeed other physiological stress, and in reflecting our overall calorie intake the previous day. And lastly, and more simply, we have a flat basal insulin delivery, except in the post-absorptive state. Now, presently, except for basal insulin delivery, we are unable to provide any of these with our current insulin therapy. And that accounts for the finding that with type 2 diabetes, no one attains normoglycemia in the sense of all postprandial on all-day plasma glucose within 4 to 7.5 millimoles per litre. And indeed, a tiny minority of people with type 2 diabetes indicated for insulin get to this range all the time either. Indeed, if you look at the average daily plasma glucose taken from clinical trials with intensive management, it's about 50% higher than normal, and we know those glucose levels are toxic. So just a reminder of the physiological profiles from non-diabetic people. In the basal state here, glucose concentrations in blue are absolutely stable overnight, somewhere a little above 4 millimoles per litre on average, and with very little variation. That's achieved by a flat and unchanging, if normoglycemic, insulin secretion. And you can show that with C-peptide as well as insulin. Then, if we look at the mealtime profile, there's this enormously quick rise in concentration. Remember, the insulin space is some 15 liters. So to fill that to 60% in 15 minutes requires an enormous output of insulin from the islet B cells. And from the peak at around 30 minutes, there's a decline to baseline again at around 4 hours. What this doesn't show you, of course, is that this is all regulated and it's made very precise to achieve this very tight glucose control even after meals. Look, the peak is occurring at less on average than 7 millimoles per litre, and it's back down to basal levels by 2 hours. Far from a peak at 2 hours, we're back to basal at 2 hours in the physiological state. And that's done, of course, because glucose levels are toxic. Furthermore, the incretin response, nothing to do with measurement of glucose levels, is very large. If you take insulin secretion and you match the glucose levels for an oral glucose level with intravenous glucose, you only get a third of the insulin output, meaning 70% of the insulin output after a meal is actually incretin regulated rather than glucose regulated. And this means our attempts to regulate insulin by glucose are intrinsically flawed, unfortunately. So within 5 minutes, then we have regulation according to our reflex calorie intake, according to our physical activity. If I was to run outside at the moment, I would drop my insulin secretion in 5 minutes, and according to acute stress. And in a few hours by these other things, including, importantly, exercise and hypoglycemia. It's interesting that the closed-loop community, in order to imitate this, has, of course, depended on trying to measure glucose. And trying to measure glucose is fine, it's important in the basal state, but it's impossible as a control at meal times. So these are hybrid systems where you actually prime your mealtime insulin secretion, as marked by the little green triangles, manually. But even then, in order to get tight regulation, they have to make the algorithms very sensitive. And you see the effect of that is far from a basal continuing insulin secretion. You get these square wave humps. The system is hunting, in fact, to try and achieve some kind of glucose control. But even during the night, it's not controlling glucose levels anything like to below 5, and certainly not even below 7. So these closed loop systems are currently not getting normoglycemia. And this is why the time in range that they've chosen goes up to 180 milligrams per deciliter, 10 millimoles per liter, and not to the physiological 7 to 8 as a maximum. So we have problems then in controlling our insulin with glucose. The areas of development that we're trying to approach that with are, of course, prevention of islet B cell decline so that there is physiological regulation, transplantation technologies which require immunosuppression, of course, islet regeneration technologies with islet B cells within the pancreas, and indeed using stem cell and islet B cell transplantation, and gene therapy, not beginning really in a clinical sense yet, but there are a few companies now looking at modification of tissues like muscle to produce insulin. Then we have insulin pumps, sensors, and closed loop systems I just mentioned, micro and nanotechnologies, and further developments of insulins and their regulations. I'm also going to address orally active, small molecule, modern insulin analogs into the future, and smart insulin systems. And there are a series of reviews of these areas in press largely in the last year or two. So very quickly, what about encapsulated microsystems for sustained subcutaneous insulin release? And the biggest problem here is that the words micro and nano don't apply to the kind of insulin load we're giving. We cannot get an insulin dose into a nano system, particularly when you try and couple it with other molecules which themselves require mass and space. So these things at the moment are still not really beginning, and as well as an insulin dose load problem, we have problems of burst release, we have problems in getting the right rate profiles for 24 hours and longer. So at the moment, a lot of work in these areas, but really it's not going any further. What about oral insulins? Well, these are superficially attractive, of course, because we want to get rid of injections. They're taken with food, and one idea is then that they match to food. The idea that you restore hepatic insulin secretion, first pass insulin secretion to the liver and make that physiological is also often touted as a reason for taking this forward. But this has problems. If we look at the LicePro studies with PEG-LicePro, which was a hepato-specific insulin, as I predicted, they got an increase in daytime hypoglycemia because of a failure to suppress the hypoglycemic rescue glucose secretion from the liver. And they got a rise in triglycerides and ALT. And these are markers of fatty liver, of course, and they would worsen the cardiovascular risk profile and mean these approaches would actually require cardiovascular outcome studies before licensing, which is why this insulin was abandoned. Further, there are profound technical problems, insulin digestion in the gut, insulin absorption across epithelia is very poor, and food, of course, interferes with the insulin profile. So far from matching to food, you actually get decreased insulin absorption with eating. if we look at what happens there, then with oral semaglutide, the day-to-day variability is actually a huge increase by 140%. And that's why with oral semaglutide, you give it daily, whereas weekly, you can give it obviously every 7 days. By giving 7 doses over the week, you decrease the variability still to around 35%, which is okay for a GLP-1 RA, but would be really hopeless for insulin. So we have problems of poor bioavailability, erratic absorption, non-physiological absorption profiles, and hepatic insulinization. And there have been various attempts to overcome these, largely unsuccessfully. This is the long investigated now pegylated insulin from known as Tegrapel. There've been a series of studies here, but if you look at the profile of insulin that they're getting, then really we're getting a peak profile around 30 minutes, which might seem ideal as a mealtime insulin, but it doesn't last out to 4 hours. And the result of that you can see is the loss of glucose control that's occurring from around 60 minutes onwards. This, I think, isn't intestinal absorption at all. I think what's happening here is buccal absorption. And indeed, if you give this insulin with food, you very quickly abolish any insulin absorption at all. So this has been in development now for over 10 years and seems to be going nowhere. Then there was the Novo Nordisk insulin. It seems to have been abandoned. And I think it's been abandoned because with bioavailability of less than 2%, we got very high variability. Fasting plasma glucose compared to our conventional insulin glargine was 90% higher in variability, and within patient variability was 52% higher compared to glargine. And these, of course, are not characteristics which are things that are happy to have with insulin because of the hypoglycemia problem, even if you do manage to get overall glucose control, which is similar. The Uramed insulin has gone further, but has huge problems. These are the phase 2 studies, phase 1, phase 2. You see with 8 milligrams, there was no increase in glucose lowering effect. With 16 milligrams, twice the dose of the 8 milligrams, they appeared to get no effect at all. And again, when looking at 32 milligrams in bigger and bigger doses, there was no increase in glucose lowering effect, suggesting, in fact, these aren't insulin at all. This is due to some kind of study effect. Indeed, baseline HbA1c was 8.9%. They got a reduction of about 0.5%, and that is the kind of reduction you see with studies anyway. And it's quite honestly a pathetic reduction compared to the hyperglycemia beforehand. They've gone forward into phase 3, and a stop press announcement this month was that phase 3 development in the type 2 diabetes study was completed, and we should see top line results early next year. But as I've suggested, I'm not very confident that we'll see a useful result here. What about faster acting analogs? Well, these have gone a little bit further in the last year. We, of course, already have faster aspart and Lispro licensed with some improvement in mealtime glucose excursions, but actually no clinical or useful improvements in glucose control or hypoglycemia overall. And furthermore, there have been some pump cannula infusion site problems. It's possible, in fact, that further developments in insulins will alleviate these problems. Within the past year, we've been told that the biochaperone Lispro from Adosia, together with the Chinese company, has started recruiting now into phase 2. And we've seen some new results with an insulin I hadn't heard about before, which I'll show shortly. The SurfBio ideas from Apple and colleagues continue to be better funded also over the last year. So this is the new AT278, and you notice that this is a high concentration insulin, which we'd expect to be much slower absorbed in fact. But compared to insulin aspart, the conventional one, we see this very fast rise to a peak indeed at 30 minutes and decreasing nicely out over 4 hours. So this is a very physiological peak. And it's getting the right pharmacodynamics, it seems, on the clamp studies. So this again looks very interesting. It'll need to go into phase 3 and be further tested to see whether we can get useful and better glucose lowering and improvement in mealtime profiles in phase 3. But this looks very encouraging. And of course, the U500 will be useful in type 2 diabetes. As far as weekly insulins go, as I commented last year, a lot of these seem abandoned, but the insulin icodec from Novo Nordisk continues to be developed in phase 3, and the Eli Lilly FC fragment coupled insulin similarly. If we look at these, the major problem with the weekly insulin is its peak trough insulin. Once daily insulins have a significant peak trough ratio, even the flat ones, but we can accommodate that by giving them at the best time of day. For once weekly insulin, though, a profile with a peak and a trough is a potential disaster, because basically it means that on one day of the week, you'll be giving to your patient more insulin than you will at the end of the week. So a peak trough ratio of 1.2 would, for example, mean a 20% higher dose, say, on a Tuesday than on a Sunday. And we'd expect as a result of that control problems and hypoglycemia problems. Thus, you need a very long half-life of the order of 3 weeks, but also after each injection, no kind of burst effect occurring at 1 to 2 days. This is the data from the Lilly insulin. There's little in the public domain at the moment, though they have submitted further material. You can see they're getting their peaks here around 3 days, possibly 4 days in human volunteers and type 2 diabetes similarly. But this actually is giving a half time of absorption, which is quite suitable at around 3 weeks. And the peak to trough ratio is about 1 to 1 or 1 to 1.5. So this probably is a tolerable peak to trough ratio for use in type 2 diabetes. Though again, I would have my doubts for appropriate use in type 1 diabetes. This insulin is in phase 3, and perhaps we will see some results next year. This is the Novo Nordisk insulin. And this, I think, is a little more problematic, although, again, it is in phase 3 because the peak trough ratio is somewhere above 1.34. So here on if we inject it on a Monday morning, on a Wednesday, you're giving 30 to 40% more insulin than you would by the Saturday. And this is likely to give problems over hypoglycemia during the week. Unfortunately, Novo Nordisk in their studies have not broken down weekly control as yet. There was one quality study from Rosenstock et al. Published in 2020 with some advantage over the conventional U100 insulin glargine, a small advantage perhaps, but certainly non-inferior to U100 glargine. But hypoglycemia underpowered in this study, so you can't really tell, but as a safety signal, a 70% increase in hypoglycemia, which, as I said, hasn't been broken down by time of week. But remember that figure, a 70% increase. Furthermore, insulin U100 wasn't optimal in that study as far as HbA1c was concerned. So this would be certainly a popular insulin. It would reduce the number of injections markedly, but it has its problems, I think. There was a press release on their Onwards 2 study, type 2 diabetes, at the end of last month. They did a 26-week study against degludec, no difference against HbA1c demonstrated, but the headline effect for hypoglycemia was not happy. It wasn't statistically significant, but it was clearly underpowered because nominally 150% increase in hypoglycemia. So the problem that we saw in the Rosenstock study apparently being reproduced in the phase 3 study. We'll hear more about that, no doubt, later this year. Quickly, I'll move on to small insulin mimetics, non-peptides, if you like. Difficult to engineer. Insulin's 3D structure is difficult to mimic. You notice perhaps on the artificial intelligence, we've now been able to mimic 30,000 different proteins for their 3D structure, and one of those is not insulin. It's not a stable structure, and it's difficult to imitate. Furthermore, we have troubles over the binding of insulin, which is complex with multiple sites of insulin interaction and conformational change on insulin. So these small molecule insulin mimetics, again, going nowhere at the time. So what about glucose-sensitive smart insulins? We note that these are still largely to be given by subcutaneous delivery, and as such, they do not overcome the subcutaneous delivery problem with its half time of 45 minutes as against the 5 minutes for intravenous insulin delivery. The idea, of course, is to modulate the activity of circulating insulin by plasma glucose, which again doesn't overcome the incretin problem, and it doesn't overcome the regulation on a 3 to 5 minute basis. So neither approach can emulate the reflex and incretin stimulated delivery of insulin. But it may be that these would give a very nice basal control if we could actually get an appropriate dose response curve between 10 and 5 millimoles per litre glucose. So how's this going? Well, of course, the lectin receptor competition for monosaccharide insulin with substitutions. Here's insulin, here's the saccharide substitution. And the idea is this would be removed by the lectin receptor when glucose concentrations are low. But if there was a lot of glucose around, these would actually block its removal, therefore increase the insulin concentrations, giving more insulin receptor mediated insulin effect. So it's a nice idea, but it didn't work out in practice. And this is the clear reason between normoglycemia and marked hyperglycemia. There was actually only a 25% increase with this Merck product in available insulin concentration. In practice, it looks as though you would require about a 10 times increase for normoglycemia and about perhaps a 5 times increase to get some useful insulin. They got a tiny increase. Clamp studies, no glucose dependent change was significant, and they returned the insulin to the developers and have abandoned it. The idea of a glucose-sensitive insulin where insulin binds with high affinity to insulin and you lose the concentration to interfere with the shape of molecule is quite interesting because maybe you'd get some intravenous and fast modulation. But there is actually no candidate and no insulin available at the moment. The way it works is simply, this is the insulin molecule that's active. You attach a side chain which interferes with the binding site so that the insulin becomes inactive. But when the side chain binds with glucose, it then moves out of the way and you have an active insulin again. So maybe this will be able to be taken forward if we can get a good enough dose response curve between glucose concentrations and insulin activity. We did hear that Novo Nordisk were going to promote one of those and tell us about the studies at the end of last year, but we've not had any further announcements even to the investment community. So my conclusions, last slide then, are that technical developments in insulin are making very mixed progress with ever faster acting insulins, which may be useful, but that's in particular, I think, within closed loop insulins. Weekly insulins may reduce the injection burden, but we have titration, we have weekly profile issue. Oral insulins seem unlikely at present to solve the problems of erratic absorption and low bioavailability, but I'd love to be proved wrong. Hepatospecific insulins are undesirable in the current obesogenic food environment. We'll hear a bit more about that from the next speaker. Small insulin molecules going nowhere because insulin is such a difficult molecule to imitate currently, and smart insulins still have to overcome the steep activity glucose response rate profile. I think regenerative medicine possibly can theoretically overcome some of these barriers because, after all, it moves towards IV sensing and IV delivery. But scientific progress is likely to be slow, and we will still have issues over physiological islets because they require very high oxygen tension to deliver all that insulin at mealtime, over control of cell proliferation. We don't want glucagon and insulin producing tumors, and over continued immunological issues. I thank you for your attention. Hope that was useful to you.
Thank you, Professor Phillips. It was a wonderful and elegant talk. Totally enlightened the whole history of insulin, and also given the nice information on the insulin history and insulin biology, and given the insights on the abuse of insulin therapy, the physiological need, and insulin profile in non-diabetic people, especially given the beautiful insights, and increasing effects on insulin also given the good insights over there. And regarding with the oral insulins, also you gave a good information on the pros and cons. And you enlighten us on the upcoming latest mealtime analogs, so-called as U500, 8248. And you emphasize more on the upcoming basal insulins, both with Lilly as well as the Novo Nordisk Pycoduct. And also we enlighten more on the glucose-sensitive smart insulins. Thank you very much for the wonderful talk, sir. Thank you very much. So without much delay, I go to the next question. Yes, Manoj, sir.
Can we ask a question? Is Dr. Home there?
Yes, Manoj, sir.
Oh, Dr. Philip Home is there?
Yes,
I'm here still. I was not expecting questions, but if it's up to the chairman,
right. So
happy to answer questions.
Yes, Dr. Home, as the chairman here and as the organizing secretary, let me thank you for that wonderful presentation, giving an overview of all the development of all the current insulins being developed. My question to you, sir, is amongst all these insulins that are currently in the development, which one are you most excited about?
You're cutting out a bit, so I missed exactly what your question. You said amongst all the insulins.
Manoj, your voice is breaking. Voice is breaking.
Okay, amongst all these new insulins, let me put my video off.
Yes, certainly.
Insulins, which one are you most excited about all from all these new ones?
Oh yeah, okay. I don't want to express preferences in the set for basal purposes in type 2 diabetes. The so-called basal insulin Lispro is looking good at the moment. It has the right profile. It has 3 weeks delivery. There will be titration problems getting there, but I think that is looking good. So in the shorter term, I think that's good. I like the Aracor fast-acting insulin. That seems to me to be getting towards a mealtime insulin profile, albeit unregulated, which is good, and that will be useful, I think, particularly if it's stable in closed loop and pump systems. So those two are the things I would be looking to. But, you know, I've been proved wrong happily before.
Absolutely. So we await those results. I think exciting times in the insulin development phase currently moving ahead, sir. Thank you so much.
It would be good to come to India and talk about these things in 2 or 3 years' time.
Absolutely. We would love to host you again, that time again in person.
Manoj, I request Jyoti Dev to take the next section. Dr. Jyoti Dev is online now. Dr. Jyoti Dev?
No, Kanan, Dr. Jyoti may not have been able to join. So let me continue here and welcome Dr. Roy Taylor, who's the medicine and metabolism at Newcastle University and Newcastle Hospital NHS Trust, co-founder of the British Association of Retinal Screeners, qualified in medicine at the University of Edinburgh. I don't think Dr. Roy Taylor has been able to join us. We do have his recorded message and would request RX to start this.
Ladies and gentlemen, I'm delighted to join you here from Newcastle, UK. This first slide shows my research centre, the Magnetic Resonance Research Centre, because this is the technique we've used to look inside the body and unlock some of the secrets of physiology and type 2 diabetes. So let me move on without delay. None of my disclosures are relevant, and consider where this work started. It started back in 2006 when the idea occurred to me that type 2 diabetes had to be a simple condition. Our work to that point, and the work of others, had shown that insulin resistance in the liver was primary in causing the blood glucose to rise. But I was puzzled by these two defects. Why could such a simple common disease have two completely separate pathogeneses? In the textbooks, it was alleged that there were different causes for the different problems in the beta cell and in the liver and muscle. But that could not be. So I came up with the twin-cycle hypothesis that by eating just a little bit too much extra for a long period of time, excess liver fat would build up. We had shown that this would cause insulin resistance and plasma glucose to rise, but very clearly it was possible that excess fat in the liver would result in excess fat being exported to the rest of the body. Now, that should be stored safely in subcutaneous adipose tissue. But just what if the adipose tissue storage was relatively filled and it had to spill over into ectopic sites? Now, one of those ectopic sites is the pancreas itself. We'd known since the classical work of Roger Unger in the 1990s that chronic excess fat supply to the pancreas would cause a decrease in insulin-stimulated, glucose-stimulated insulin production. So beta cell dysfunction would result. That was the hypothesis. But of course, we could test it. And this is a matter of trying to destroy the hypothesis. We could instantly show it was wrong by taking people with type 2 diabetes, reducing their weight. The liver fat would surely go down. If their diabetes didn't go away, then the hypothesis would be wrong. Well, we did the counterpoint study, and this showed that in type 2 diabetes, there was indeed excess liver fat. There was indeed excess fat export from the liver. There was excess fat inside the pancreas, and we already knew that the beta cells did not work very well. But dramatically, with the weight loss in the counterpoint study, we were able to show that we changed this into normal levels of liver fat, normal fat export, normal pancreas fat, and restoring beta cell function. How do we do this? Merely by using a low-calorie diet. It had to be quite a strict diet, because for this study, we needed to observe the changes in a short period of time to be certain that we were really observing cause and effects. So the counterpoint study confirmed that type 2 diabetes was a simple condition. We had to move on to find out more. And over the last 14 years, we've carried out 4 major studies, and the one that is just about to be reported, and I'll mention some of the data from ReTUNE at the end. But the counterpoint study, as I've just mentioned, showed that fasting blood glucose gets back to normal, absolutely normal, when we stop the oral hypoglycemic agents and start a low-calorie diet. Within 7 days, fasting glucose is normal. It showed the mechanisms, the 4 big mechanisms: the liver fat, the fat export, the pancreas fat, and of course, the insulin secretion. But it left open major questions. And so we carried out the counterbalance study, which answered 2 major questions. Firstly, in counterpoint, we'd studied people only of duration up to 4 years type 2 diabetes. What would happen with longer duration diabetes? Well, in counterbalance, we studied people up to 23 years duration. And we showed very definitively that the shorter the duration, the more likely it was to get remission. And indeed, beyond 10 years, remission was not at all common. It also showed, this counterbalance study, that remission was entirely durable. There is a myth circulating that beta cell function inevitably goes downhill in type 2 diabetes. But this has come about by studying groups of people who do not lose weight. They maintain the stress on the pancreas. The pancreas fat remains high. And surprise, surprise, beta cell function goes down. But specifically take away that metabolic stress, and the beta cell function returns to an adequate level and does not go downhill. That's sort of dramatic finding. We only observed it up to 6 months in counterbalance, but in subsequent studies for much longer. But there were lots of people on the sidelines who said type 2 diabetes can't be that simple, and were very skeptical that the fat inside the pancreas had anything to do with it. Well, in the pancreas study, we achieved a demonstration that acute weight loss causes loss from the pancreas fat compartment only in people with diabetes. They start off high and they fall. I'll show some of those data. And then in the direct study, we showed that remission can be achieved in primary care. This is something simple that any doctor, indeed, as in the direct study, any nurse in primary care can achieve with sufficient information about how to support people lose 15 kilograms in weight. Now, this again is our MR Centre, and in the spring we have our lovely laburnum trees. But of course, looking at nature allows one to think. And if we just think about the points I've made, you'll see there might be a problem. Because some people with type 2 diabetes look normal weight. And indeed, in India, there are many people with a lowish BMI and type 2 diabetes. Could it be that there are the same processes operating then? Or is the diabetes really due to some mysterious other cause? Well, we can find out. And this whole thrust was powered by the personal fat threshold hypothesis, which I published together with Rory Holman in 2015. And the reason I published this was that I had observed that people with unremarkable weights could get rid of their diabetes by losing weight. But of course, that was just clinical observation. If we consider 3 people, 3 men aged about 45, and if I was to ask you which one has diabetes, I think everyone would say, well, almost certainly this one, and possibly this one too. Not at all that one. But that's wrong. 10% of people with type 2 diabetes in the UK have a normal BMI. Now, adjusting that range for India, the same is almost certainly true. But let me make the point powerfully by showing you what each of these men looked like when they were not 45, but when they were 25. This man played chess and was a cross-country runner. This man played rugby and did weightlifting. This man did some of both. But you see, each of them have put on an equivalent amount of weight. Weight gain in adult life is almost 100% fat. We may like to delude ourselves, but if you weighed 70 kilograms at the age of 25 and you now weigh 80 kilograms, you have gained 10 kilograms of fat. So this weight gain will be fat, but what if the subcutaneous compartment was relatively small, the capacity was too small, and it spilt over at a lower threshold? Well, that person would then get the diabetes that we were observing. So individual thresholds for susceptibility to excess fat could determine the risk for type 2 diabetes. That was the personal fat threshold hypothesis. So let's test it. And we tested it in the ReTUNE study. And the aim of the ReTUNE study was to test this hypothesis. People who develop type 2 diabetes have stored more fat than their own body can manage. So a very specific personal message for the patient in front of you, nothing to do with epidemiology. Do remember that the larger a study is, the less relevant its results are likely to be for the person in front of you. What did we do in ReTUNE? Well, we studied the mechanisms, of course, by looking at the big four, the liver and pancreas fat, and the fat export, and the beta cell function. But we did this by achieving weight loss of first 5% and keeping it steady, then 10% and keeping it steady for a further 8 weeks, and then 15% and keeping it steady. And then we followed up people at 12 months. So this was trying to identify the threshold. How much weight did an individual need to lose to get rid of their diabetes? And anyway, in these people with a lower BMI, this is regarded as normal or very close to normal in the UK, would these people have excess fat causing their diabetes anyway? Well, this is a weight loss we achieved. Here we have the BMI. To start with, it was around 25, just under 25, and it went down exactly as we had planned. This group requiring 15% weight loss is relatively small and not representative because the protocol stated if people had already achieved remission by the second step, then they wouldn't proceed to the third step. But between the end of weight loss and 12 months, there was no weight regain. Here are the same data, just plotted as weight in kilograms. Down, down. So we could find out what would happen at each stage. But how about the headline figure? Well, in people who look slim but have type 2 diabetes, the total body fat content is grossly increased. In this group of people with a normal BMI, we found that they had a total body fat content of 32%. That's way above the normal range. The controls, matched for weight and everything else, had a fat content of 28%. So you see, there is excess fat, but is it there in the organs, and is it clogging up the processes in the same way that we now know for certain in ordinary overweight-associated type 2 diabetes? Well, the first point to make is that 70% of these slim people achieved remission of their diabetes. That's a dramatic figure. Taking people with a life-threatening condition, a high incidence of coronary heart disease, a high incidence of amputation, all the general ill health and premature death, and turning them back into normal people with a normal 10-year cardiovascular risk profile, that is quite remarkable. Now, what is remission? We say 70% achieved remission. Well, just last year, an international consensus panel to which I contributed defined HbA1c of 6.5% and less as being remission off all hypoglycemic drugs, and provided there are 2 tests of HbA1c, a repeat at 3 months to demonstrate that the remission is still solid. So we could take people out of this range of diabetes, but what was really happening inside the body? Well, here I show you the data from our direct study, which had overweight and obese people, and you'll see that in type 2 diabetes, liver fat was really very high compared with the controls. But there was a surprise with the ReTUNE dataset because liver fat seemed to be in the normal range. How could this be? Well, of course, this is a matter of calling into question what we assume is normal. You'll remember that this figure of 5.5% liver fat as being defined as the border of normality was derived in the San Antonio Heart Study. And this was conducted, of course, in America. And in America, the population is not notably thin. This normal range has been devised on an overweight population. If we look at people who are matched for BMI, you'll see that there is over a 2.5-fold difference here between people with diabetes and those without, and over 2.5-fold difference here. There is excess liver fat. And indeed, the threshold we identified in ReTUNE was that weight loss of approximately 6.6% of starting weight would achieve remission of type 2 diabetes. That clearly related to this fall in liver fat from a level that is grossly abnormal for a person of this body mass index. Similarly, with the pancreas fat, we showed the small difference we've already described as being present between non-diabetic and diabetic, and indirect. This fell during the weight loss. Also in ReTUNE, there was a highly significant difference between diabetes and non-diabetes. So we can be confident that this is a condition of excess fat in the organs, whatever the BMI. Well, let's go out into Newcastle City itself. This is our new castle. It gave rise to the name Newcastle, but in fact it was built in the year 1186. And only 300 years later, our cathedral was built, and it's still standing from 1486 to the present day. But in Newcastle are all the people. How do we take this science out to the people? Well, we have to define exactly what it is we need to do. A diet for weight loss. What are the characteristics of this? And in producing this slide, I'm bearing in mind the natural cultural differences, say between India and Newcastle. Of course, people need to eat differently in these places, but the diet we need for weight loss really transcends that. The first point about it is that it has to be simple and practical for people to be able to follow in their everyday life. We need to recognize that individuals find it very difficult to diet because humans are social eaters. We eat in family groups. We eat with friends. And for that reason, it's absolutely vital that the spouse or partner is on board right from the start. Please don't send an individual to see a dietitian. In fact, unless the dietitian is tuned into this matter of weight loss, don't send them to a dietitian at all. Because we need a very specific approach to losing 15 kilograms in a short period of time. And this short period is important. Not because we wouldn't get the same effect if we lost this weight over a much longer period. Of course we would. It's just shifting the fat out of the pancreas just the same. It's the human factor. It is more difficult to lose weight slowly. On the low-calorie diet, hunger, remarkably, is not a problem. People are quite happy on this. Indeed, one of the main problems is persuading them to come off it at the end and get back into normal eating. So duration limited is important because this is goal-directed behavior. You want successful treatment. Your patient wants a successful outcome. We need to achieve this in a humanly defined period of time. 8 weeks in the Counterpoint study. So, what else can we say about this matter? There's one really important point. The textbooks and the magazines are full of exercise for weight loss. And in respect of the weight loss itself, I have one message for you. Don't do it. When people with type 2 diabetes embark upon a diet, embark upon exercise, they will indulge in compensatory eating. That's why, as many people in this audience will have found out for themselves, starting an exercise program is usually followed by no change in weight. If an exercise program is started at the same time, it's more difficult to lose weight. So focus upon what's important, weight loss. Once the weight loss is completed, physical exercise is really very important to encourage to help prevent or slow weight regain. But we need to be quite clear that we need both, but frame shifted in time. Lose weight first. Do not exercise during this time. Then increase the amount of exercise. Your patients will come back and say, I feel 10 years younger. I can play with the grandchildren again. I can run up the stairs. Exercise becomes feasible when it has been very difficult before. So, what is the wider program? Well, the wider program is to achieve weight loss rapidly, and we used a 600-calorie liquid formula diet and non-starchy vegetables, such as salad stuffs and any leafy vegetable. But the nature of the diet is much less important than the amount. Secondly, to move from this back towards normal eating, we stop one of these meals and introduce just a normal meal, but a small meal. And this defined amount of food to eat is quite important to mention. Here we see the entire day's allowance of non-starchy vegetables piled on the plate. And these are our diet replacement products made up in a pint of water. There is your breakfast. There's your lunch. There's your dinner. This achieves one of the important things about a diet. Usually, one of the big problems of losing weight is the day-to-day burden of decisions. Can I eat this? Can I eat that? This burden is cumulative. But by simplifying this to very clear instructions, we avoid this problem. Now, this diet is something that doesn't have to be used, but in one particular study in India, it was indeed used, or a similar diet was used. Now, it was felt that 1,000 calories a day would be more acceptable. And indeed, this demonstrated that 50% of people had no diabetes at 12 weeks. They had only lost 6.5 kilograms in weight, but just look at their HbA1c drop, and oral agents were stopped at this point. You can see this is real, this is practical and doable. Long-term avoidance of weight regain remains the big challenge. But let me put over to you some really important points. Diabetes does not recur if the weight loss is maintained. So if people avoid regaining weight, they will stay free of diabetes. That is, until very late on in life, when mobility is severely impaired. Very quaintly, they will get maturity onset diabetes, and it doesn't matter beyond the age of 80. It is not a serious condition. It's people getting type 2 diabetes in early life who have the most problems. Now, this is a challenge to avoid the weight regain. A few people can indeed manage it by themselves. They are self-motivated, but most people need ongoing support, and this is absolutely critical. So you may well achieve freedom from diabetes for your patient, but your patient still needs to come and see you for the ongoing support because there is 100% certainty. Few things in diabetes can be said to be 100% certain, but this is one. There's 100% certainty that diabetes will recur if weight returns to its previous level. You can promise your patients that, and you can promise them that things are likely to be better if they continue to come and see you on a regular basis for the weight to be measured, for a discussion about their physical state and also their physical activity. So, if I was to pose the question, what is type 2 diabetes? I hope you'll now agree with me that type 2 diabetes is a state of excess fat inside liver and pancreas. And more than that, if we remove that fat, the diabetes can go away, provided the beta cell damage has not become too established, with duration of diabetes being too long. But importantly for India, with low BMI type 2 diabetes, ReTUNE confirms the same pathophysiology as in heavier people and the same remission with weight loss. So major implications for clinical care. That takes us back to the Magnetic Resonance Center. And in the early spring, we have this beautiful cherry blossom, a nice place for people to sit and think. But I hope you now think what I think about type 2 diabetes. It is a simple condition of excess fat inside liver and pancreas. And recognition of the personal fat threshold is important. It's the most understandable concept for patients. When I explain this to them, they seize it much more rapidly than any other concept. And type 2 diabetes can be reversed by simple means. Now, simple shouldn't be confused with easy. It is a challenge for anyone, but with support and with focus upon what's important, this is something you can achieve for your patients. Thank you.
Oh, thank you very much, Professor Roger. It's a wonderful session and very excitable also because already you are one of the directors for the direct trial and we have enlightened more on the good insights on the twin cycle hypothesis, the importance of the liver fat and pancreatic fat and paving the way for the diabetes. We are given the interlink between the pancreatic fat and this one liver fat and also type 2 diabetes and even the importance of both the calorie restriction and the weight loss. And more than that, even the real hypothesis on both the direct trial as well as the ReTUNE study and hypothesis. Thank you very much for the great enlightening talk, sir. Thank you very much. Over to Professor Manoj Chawla.
No, I think we had a great session and would like to thank all the speakers who've taken time out and joined us from different parts of the world for this wonderful session. And of course, thank the chairpersons and doctors helping us with the hall, Dr. Snehata Verma, Dr. Karan Natarajan. Truly appreciate your efforts for Diabetes India and that Congress. Would like to thank again Dr. Philip Holm for joining in and staying back, and RX Events for helping us with this entire aspect. So, Dr. Holm, many regards and thank you again for the teaching. We surely would love to have you here in person again in India in the near future. We look forward to that. With that, we end the session and have a wonderful Sunday, everyone.
Thank you, Manoj. Thanks.
Thank you, sir. Thank you, everyone.